Hello everyone. It's my pleasure to introduce our last speaker of our CNODES monthly seminars. Today's speaker is Dr. Michele Jonsson. She's an associate professor of epidemiology and director of the Center for Pharmacoepi at the University of North Carolina, Chapel Hill. Over the past 17 years, her research has focused on the intersection of pharmacoepidemiology and methods for estimating valid effects in real-world data with specific applications in women's health research. She also has methodological expertise in the estimation of drug effects using non-experimental data, evaluation of treatment, effect heterogeneity, implementation of propensity scores, doubly robust estimators, and different methods to address bias due to measurement error, as well as expertise in data linkages. So it's our pleasure to host Dr. Michele Jonsson. And Michele, the floor is yours. Thank you.
Thank you so much, Laurent. And it's I'm really excited to be speaking today, and hopefully we can have some dialogue at the end. I've been more restrained than normal in trying not to pack in too many slides. So please feel free to enter questions in the chat box as they come to you, and we'll try to take the more meaty questions at the end. But if there's a clarifying question, I'm happy to pause and take care of that along the way. So welcome. My topic today is fairly broad, using real-world evidence to improve public health. And briefly, I want to highlight my disclosures. I have funding from a number of different sources, and I'm also the director of the Center for Pharmacoepidemiology, which is supported by GlaxoSmithKline, Takeda, AbbVie, UCB, Boehringer Ingelheim, and formerly Merck. So let's talk about real-world evidence. I'm sure you've all heard the latest buzzword, especially for those of us who are doing pharmacoepidemiology. And a quick Google search shows that basically everyone and his brother is generating RWE. So what is it, and how can we be using it to improve public health? So I guess it's no surprise to this audience that we've been generating RWE for decades. We called it comparative effectiveness research, or evidence-based medicine, or just pharmacoepidemiology. So the name is new, but the methods and issues are pretty well trafficked territory for us. But one of the things that the sort of focus on this term RWE has done is maybe help solidify our thinking about what are the inputs that we need in order to have really robust RWE. And I've adapted this figure from the Duke Margolis white paper on RWE to highlight a couple of different features that I think are really important. So first, we have the decision-making context. Who is looking to use this information? What kind of decision are they needing to make? And what are the consequences of being wrong? And finally, how quickly is that information needed? The clinical context is, obviously a key input. How common is this disease? How uncertain are we about the relative benefits and risks of existing therapies that are already being used? And what's the expected size of this treatment that we're looking for? Expected size of the treatment effect. So are we looking for, a 10% change in something that's exceedingly common? Or are we looking for a hazard ratio of 4 for something that's rare, or somewhere in between? So with that context in mind, then we have to think about what are the data that we have in the real world that might be brought to bear to this, with considerations of missing data, data quality, as well as just the sheer numbers. And then in concert with that, we think about how might we approach this from a study design and analysis perspective. So all of these together need to feed into this decision about whether or not the data that we have and the methods that we use will generate some fit for purpose RWE. I'm going to start with diving a little deeper into the real world data side of this, because I think particularly now, there's been an explosion in data available, and yet the quantity of data doesn't somehow absolve us from needing to really understand the quality aspects of it. So the first thing I want to think about is, something that we are all faced with when we design studies using large secondary data, and that is defining some period of continuous enrollment. We're often use this baseline period as a sort of a washout in order to eliminate individuals who might already have had the outcome that we're looking for, so that we can identify individuals with an incident event. And historically, we've favored having uniform periods, baseline periods in which we assess this for everyone in the study, in order to avoid potentially having differential quality of information on some individuals. So that's sort of the context in which we come to this question. One of my dissertation students, Mitch Conover, wanted to dig into this a little bit more and try to understand, in the context of US Medicare claims, whether using more of the available history might be beneficial. So he specifically went in and compared different amounts of fixed look-back windows, as well as using all available data to try to characterize what proportion of statin initiators or non-initiators had a history of a cancer diagnosis. So the idea would be, if we want to look at hypothetically an effect of statins on incident cancers, we obviously need to make sure that we don't have prevalent cancer patients in our study population. So the top set of darker lines shows us populations that have been defined using a 1-year fixed look-back period, which, at least in US data, is very often sort of what we default to, because a longer look-back means you throw away more people who don't meet that continuous enrollment criteria. And what we're looking at is the proportion of individuals who had a history of cancer in their more distal data, even after imposing this 1-year look back and excluding everyone who had a cancer diagnosis code, procedure code, any what we would call any whiff of cancer, a very sensitive algorithm in that time frame. And what we see is that statin initiators, the lower line, had, in the most recent year of data, which therefore means the longest potential look back, 18% of those individuals had some indication of a history of cancer. And in individuals who were not initiating statins, it was 23%. So this is a fairly large proportion of our study that is contaminated in a way with individuals who have already had a cancer incidence and may well show up in our follow-up period as sort of not a new cancer, but as some kind of recurrence of this past cancer. And then these lower set of lines indicate what happens if we use an even longer look back. So using 3 years of data for everyone, we still see a pretty substantial difference and relatively common presence of a prior cancer diagnosis. So in addition to just the sheer numbers here, what's concerning to me is how big the differences are between the two treatment groups that we're looking at. So given this gap between the two, even with a 3-year fixed look back, we would expect to see, if we were only using those 3 years worth of data, some quote unquote protective effect of statins, simply because that population has fewer prevalent cancer cases embedded within it that we might misclassify as new cancers. And when we look at the results, if we look at the differing lookbacks for 6-month, 1 year, 3 years, and then AA is all available, and we use those to exclude individuals with a history of cancer, we see that the SMR weighted hazard ratio for incident cancer in the 6 months after treatment initiation goes from 0.7 to 0.94, depending on how much of the data you use. So we do get meaningful changes in the effect estimate here. You know, the 3-year look back actually gives us a pretty good estimate, but 6 months is clearly too short and 1 year isn't great. So let me bring us to another challenge, and that is misclassification. And we often we often see in the results section or the discussion section of a paper some statements about misclassification of the exposure that are supposed to be comforting. You know, something like it's probably non-differential and therefore any bias would be toward the null. And since we, you know, found an effect of size X, you know, we think that the true effect is probably at least this big. But what's maybe not well understood is that that set of assumptions only works under very specific conditions. And one of the conditions is that the two groups that you're comparing are truly binary in nature. So in pharmacoepidemiology, we're often in a situation where we actually want to use an active comparator. Obviously, there are settings where it's not possible, but by and large, we think that this helps us reduce other forms of bias. But in the setting where there's an active comparator, there really are 3 levels of exposure, at least. Drug A, drug B, and the unexposed group. So I just want to walk through sort of how this plays out when we have non-differential misclassification of each of these with respect to the untreated group. So within the comparison of individuals who are observed to be treated with drug A versus untreated, here's the truth. And then here we have the observed data, and we see the sort of classic finding of bias towards the null because people are moving in between the treated and the untreated groups. So if the true effect estimate is 2, we get, you know, a slightly attenuated effect of 1.72. And now here's a second drug that we're also comparing with not being treated. And here the relative risk is again 2. So these effects are uniform. And this one is also a little bit biased towards the null. But then we do the head-to-head comparison. We're doing the active comparator study. And the sort of contamination of each of these treatment groups with individuals who actually were untreated isn't uniform. And the result is that what should have been a null result, 1.0, gives us a 1.2, a bias away from the null. So despite the fact that the comparison in the analysis phase is a binary one, the true underlying data are not binary. There are at least 3 levels of exposure. And we can't invoke this sort of usual assurance that any bias that is non-differential in nature would be toward the null in the case of misclassification of these active comparators. And for those of you who are interested in this and want to follow up more, Rachel Ross has been working with me on some additional findings that will be presented at the SER meeting next week. So I invite you to join her, the session on pharmacoepidemiology, to hear more about that. So the next sort of wrinkle in our data that I'd like to talk about is about the timing. So assuming we correctly classify the individuals who are exposed to a given drug, the question is, are we capturing the onset of use accurately? And timing matters because of time-varying hazards and the potential for selection bias. That is, individuals who don't have an adverse drug event and do respond to the treatment are more likely to continue using it. So in most settings, we want to capture that initial period for each of the drugs that we're comparing. So in this example, Jess Young, when she was still a student, used linked data. She took Medicare claims data, and there's a linked survey that is conducted in Medicare beneficiaries in the US, where they collect information about the medications that patients are using over time. And she could map those with their claims data. And what we found was that if we had a cohort of individuals who we thought were new users of statins, and then we looked back into their MCBS data to try to see if they had evidence of prior statin use before their initiation of statin based on the claims, overall 20% of those individuals actually had statin exposure in what was supposed to be the washout period. And the place where this was most pronounced was in January and February of the year. And our hypothesis is that this relates to the benefit design for Medicare as an insurance plan, that because there were probably some incentives or limits on your coverage for drugs, that at some point in the previous year, it might have made more sense to just pay for this drug out of pocket because you had already hit the limit of how much Medicare was going to reimburse for. And then the new year starts and your benefit kind of resets. And a lot of people who appeared to not have recent claims come back in again and start using their insurance benefit to cover their statin prescription. But it does mean that if the proportions of individuals who are at different stages of treatment initiation differs across the drugs that we want to compare, and the hazards of the outcomes we're interested in are changing over time from initiation, this can also be a source of bias. This was just one other deeper dive to show that, you know, we could do something about this. We could exclude individuals who are likely to have already been exposed to the treatment, but it's really painful to do that. In order to exclude all of these groups who were more likely to have already had prevalent use, we get down to 25% of our original cohort size, and we still have 12% of individuals with prior use instead of 20%. So it's not a very satisfying solution. Another challenge to think about in our data is to what extent do all of the healthcare encounters that we think should appear actually make it into the data that we're using. So the market scan data is used pretty heavily for pharmacoepidemiology research. And at least in the US, this includes the Medicare supplemental data for those over 65. So one sort of interesting wrinkle about this is that because it is supplemental, it is secondary to Medicare, which would be the primary payer. But there are some types of services that Medicare pays for in full. So our question in this was, would those healthcare services that Medicare pays for in full even show up on the market scan side? Because in theory, there's nothing for them to pay. There's no benefit to coordinate. So this is an example of some procedures where there's no patient copay, and others where there's a 20% copay for the patient. And so we looked at a lot of these, but embedded within this is a nice natural experiment. So on January 1st of 2011, Medicare waived the coinsurance and deductible for annual screening mammograms. So prior to that, there was a 20% copay, and after that, it was zero. So this seemed to present a nice opportunity for us to see whether or not the rate of those claims would be stable over that transition, or if there might be a change that would indicate that we are missing information on the market scan Medicare population. So these are the results, and we're looking over several years of data here. And as you can see, the orange line at the top is a rate per person day for screening mammography in Medicare. So these are what we might think of as the quote unquote true data. So these are Medicare claims. The yellow line right below it is the rate for screening mammograms in MarketScan. And as you'll see, there's a fairly precipitous drop in January of 2011 when this change in the copay emerged. And then as sort of a control, we see the curves for diagnostic mammograms below. And those are less common than screening mammograms, but they're stable over time. And for this entire period, the diagnostic mammograms carried a 20% copay and there wasn't a change. So I would say this exercise really underlines the need to understand where our data are coming from and even intricacies of insurance benefit and coverage limits for individual procedures over time. And I'm not claiming that it's fun to dive through the governmental documents about exactly which procedures are covered, but I think this does a good job of illustrating how critical that is so that we can use the data to good effect. Another challenge that we run into is ascertainment of death. And specifically in some of the data sources that we use, deaths are not captured unless they occur in the hospital. This isn't unique to MarketScan, but that happens to be the data source that we use for a lot of our research, and that we were concerned about the inability to differentiate between individuals who had changed their insurance plan versus individuals who might have died. And since we're only going to capture mortality that occurs in hospital, it's fairly concerning that the majority of deaths occur out of hospital. And it's higher for some types of causes of death than others, but overall it's at least 50%, and in some cases north of 75%. So regardless of whether we're interested in death as an outcome itself, or if we're thinking of this as potentially a competing risk, we really need to understand who's alive and who's not in our data. So what we were hoping we could do is identify information about the patient leading up to what appeared to be a censoring event, and find something in there that would help us differentiate between individuals who had actually died and those who were truly censored. And because we don't have access to the true death data, we partnered with Truven, who was the sort of keeper of the MarketScan data at the time, and they have linkage to death certificate information sort of in-house. They aren't able, for privacy reasons, to share that with outside investigators, but that was something that they were able to look at within their organization. And it was really, I thought it was really interesting that there were some fairly simple things that we could do, like if individuals disenroll at the end of the calendar year, it is very unlikely that that is an indicator that they died. And similarly, maybe as expected, if they had a claim for hospice-related care, it was very likely that they did die. And then, various things in between. And we ended up with a C statistic about 0.94, which, isn't horrible, but it doesn't, our classification overall means that, we will still misclassify a large number of deaths. And so this work is ongoing, and this was just looking at it in those over 65, where obviously death is even more common. And here December enrollment remains a strong predictor. So that would be sort of the poor man's way of handling this, is treating anyone who disenrolled in December as a true censoring event, and looking more closely at those who disenroll at other times of year. But the FDA was really interested in trying to improve this to be able to use these data for various substantive area analyses, including opioid use and overdose. So there's more coming on this front, so stay tuned. So my key takeaways for sort of the first half of this discussion around real world data and assessing fit for purpose is that, first of all, volumes of data don't necessarily imply sufficient quality. We really have to have an intimate understanding of the data generation process and understand that in the context of the requirements for a given question. And then to really critically consider the implications of imperfect data. And all of our data are necessarily messy and not pristine. So measurement error is just part of the gig. And if we understand the types of measurement error that we're dealing with, then we can actually do something about that rather than sort of wave our hands in the discussion section. So I'm going to move on to a focus on analysis. And obviously, having high quality data that are fit for purpose is important. And I would say we can't, we're not going to be able to rescue really poorly, highly flawed or a poorly designed question in the data analysis phase. So I don't want you to get the impression that I think the analysis is more important in any way. But I'm going to focus on one particular piece of data analysis, and that is thinking about how we estimate or identify heterogeneous treatment effects when the strength of confounding differs between some of the groups. So I'm going to use this hypothetical example, but it obviously could be applied in lots of other settings. So let's imagine that the true relationship between our two confounders and our outcome of interest differs by sex. So in the DAG here, among men, LDL acts as a stronger risk factor for mortality and is a predictor of statin initiation. Whereas for women, A1C is a stronger predictor of mortality and a predictor of statin initiation. So depending on the modeling approach that we use to adjust for confounding, we might assume that these relationships are the same in the subgroups. And that may or may not be a great choice if what we're trying to do is identify potential heterogeneity in the treatment effect between them. So for example, if we fit a single propensity score model in the full population, we're assuming the arrows leading into statin initiation are the same in strength for both men and women. So that type of model, and then stratifying the result to estimate a treatment effect for men and women could be biased because of residual confounding and how these have been modeled. So I've been saying the word hypothetical. So these are hypothetical differences by gender, but we actually know that these do exist in the setting of cardiovascular outcomes, where we have a validated risk score, the ASCVD risk score, that when you look it up, it has completely different sets of parameters for men and women by race. So there are other examples as well, but that's one that is relevant for this example. So our standard methods might not give us an unbiased estimate if the covariate effects differ by subgroup. And we aren't limited to sex as a subgroup that could be problematic. There are others that we could imagine covariate effects might differ by. So the objective of this work, and I'm going to do a little bit deeper of a dive here just because it's more methodologically dense, was to evaluate precision and bias of various approaches to modeling the treatment effect by sex, given that those covariate effects differed. And to do so, we set up a plasmode simulation. So we started with real data from NHANES, which is a population-based sample in the US where individuals come and answer a bajillion questions and then have labs drawn. And from that, we could then layer on a simulation in which we controlled who was assigned to treatment and who was assigned to receive the outcomes, but with the covariate relationships between these characteristics preserved intact. So the analysis for this involved estimating sex-specific adjusted rate ratios using several different approaches to the models themselves. So these are sort of our conventional conditional models. We also used G computation, where you fit that model, but then you use it to essentially predict the potential outcomes for everyone under both treatment conditions. We used stabilized IPTW, and then finally we used a doubly robust estimator, which combines the G computation with the IPTW approach. And then for the forms of these models, we used everything from just a straight up main effects model to an interaction between treatment and sex, allowing interactions between the covariate values and sex, and then a fully stratified model where we conducted all of these models separately in men and women. And then the true effects, in order to get to the bias, we had to know what the true effects were. So we obtained the true effects using simulated counterfactuals. So let's start out with the true effects and the crude estimates. So here are the true effects for men and women, and then our crude effects are confounded. You'll see there's confounding for both sexes, but it's more substantial for women in this example. And notably, there's no evidence of heterogeneity here in these crude estimates. So these are then our standard, what I think of as our conditional outcome regression models when we use multivariate adjustment in a single outcome regression model. And so these are our true estimates again, and the vertical lines indicate sort of where we want to end up. That's where the truth is. And if we just fit a standard model with an interaction term between sex and treatment, simultaneously fitting main effects for all of the other covariates, we end up with biased estimates here. And it's a little bit farther off for women than men. Neither of these are statistically different than the truth, but it's also clearly not the estimate that we're ultimately really looking for. As soon as we include more flexibility in the models, as expected, we recover the true estimates again, as long as we have the ability for the covariate parameters to differ by men and women. And this is the G computation. So this is the same type of model, but now we are using those to generate potential outcomes for each of the groups. And when we fit a main effects GComp model, we are doing it within treatment group. So in effect, this quote main effects model already has essentially a sex by treatment interaction term because they're being modeled separately. But the pattern, the overall pattern here is the same. So that works. Here are the stabilized IPTW models. And first, we're going to fit these within the entire cohort. So we're going to fit a single propensity score model. And then after we fit that and weight the cohort in order to achieve marginal balance on the covariates, then we add an interaction term between treatment and sex. So that's not giving us the result that we were hoping for. But interactions between the covariates and the treatment do get us there. So then the bottom set of models actually include the covariate interactions within the propensity score model itself. And without diving deep into those, all of those worked well. So this is the one that I found most intriguing. And this is the doubly robust model. And for those of you who are familiar with it, you'll know that doubly robust estimation works by fitting both a GComp model and a propensity score model. And at least in principle, if either one of those is correctly specified, then in expectation, you should get an unbiased treatment effect. So you'll remember the pattern that we saw in all of our other slides, that these main effect models were biased. And in this case, these are pretty close to the truth. This one's still a tad bit off, but not by much. So even the use of a main effects model without pre-specifying all of the interactions in order to build in the flexibility for these covariates to differ, the covariate parameters to differ by sex, we were still able to recover an unbiased estimate. So stay tuned. This is intriguing, and I think I'm looking forward to being able to tell you more about sort of where this leads us. But it could be really helpful in terms of assessments of heterogeneity to have something that doesn't involve having to build all of the potential interactions in order to be able to study it. So the key findings here were that including interactions between sex and our covariates means that we really have to do this for any particular subgroup that we're interested in, unless we can show that this doubly robust approach would work. And that would be really exciting. But for now, there is no shortcut. If you want to look at the treatment effects in subgroups, you really probably can't ignore the fact that the coefficient effects may differ by those. And I think the risk right now is that a more simplified approach where we fit an overall model of some kind and then report some kind of stratum specific estimate without actually refitting the models could lead us astray in either direction. It could create the appearance of heterogeneity when actually there's none there. And it can also obscure heterogeneity, as we saw in our estimates early on. So sort of a cautionary tale. So let me take just the last few minutes of the presentation to maybe project what I think the future of RWE is going to look like. We're going to have to address a number of challenges, or if you are an optimist, you could say we have lots of great opportunities for growth in front of us. So the first challenge that I see is that most analyses and designs that I see used for real-world evidence assume that treatments are point exposures. And the reality is that almost everything we study is a chronic treatment of some kind. Not everything, but the vast majority of treatments that come across my desk for studies involve ongoing therapy of some kind. And the good news is we have methods to do this better. It's just that they were not the bread and butter that we were all trained to work with. So there's work to be done there in order to sort of bring those methods into comfortable use. The next challenge I see is that we have more and more rich sources of data that have important ingredients that can be brought to bear to estimate these treatment effects. But we need to be able to integrate the right data over time. And that obviously is going to generate missingness. And so there's a lot to deal with there in terms of how to properly bring together these diverse sources and account for the uncertainty that is introduced when we do that. And then, as we've seen in the COVID pandemic, there is an urgent need to accelerate evidence generation. Randomized trials, including pragmatic trials, can take years to give us an answer to a very narrow question. And any signals, both on efficacy and safety, need to be substantiated quickly to avoid potential harm. I really believe we are poised to provide timely answers to relevant therapeutic questions But that said, the nature of what I'm showing here, the iron triangle, is that you can really only pick two. So there's fast and cheap, which won't be robust. And you'll ultimately risk doing greater harm than good. And that leaves us with third option, which is going to be expensive. And I know that's not a popular view. I think many people hope that the existence of these real world data will make everything happen quickly, but it's not going to happen without resources. So I want to address machine learning briefly, because this really has become central to our discussions about evaluating drug safety and effectiveness using real world data. And some have suggested that machine learning and artificial intelligence is going to be able to tell us everything we need to know about optimizing healthcare. And they can deliver the results in weeks instead of months or years. And maybe best of all, they can do all of this without drawing a DAG. And these tools are really good at prediction. But the truth is that predicting counterfactual outcomes is not as easy as predicting factual ones, like credit card fraud or the start of flu season. So I argue that these powerful tools have to be deployed within a causal framework. It's like our plan over here. And to answer a specific question and give us some actionable evidence. So with a plan, we can come up with something that's going to answer the question that we are trying to pose. If we don't start out with a clear plan, or the causal framework in this case, we may produce real-world evidence that doesn't actually serve public health. And in some circumstances, it may do harm. So coming back to our visual here for the world of real-world evidence, I think real-world evidence is a truly multidisciplinary space, and it takes data scientists, pharmacoepidemiologists, biostatisticians, predictive analytics, causal inference, machine learning, clinical decision-making, claims data, EHR, NLP, spatial analysis, all of that, linkage of data, integration efforts, data governance and oversight, and management of large healthcare data in order to generate really robust RWE. And I'm excited because I feel like epidemiology is a real catalyst to bring all of those different expertises together and really help us do things that are going to benefit the public health. So thank you, and I'm happy to take questions and have more of a discussion.
Thank you very much for the great talk. So we have a few minutes for questions. Okay. So I guess I'll start with one. In your earlier slides, you talked about the look back windows and how these can have an impact on who we define as a new user versus someone who could have a recent user. And I know there's like really two different philosophies about this, right? In terms of, should we limit the look back period to a fixed window, or should we use the entire look back window? And this would also apply to covariates. And I think the idea there is to minimize this misclassification, right? That could be there. I just want to get your thoughts about this, and because I know it's uncertain, at least from what I've seen in the literature. There are those really arguing both ways.
Well, I guess if it was an easy question, we would have already solved it by now. In the work that Mitch and I were doing, it really depended what it was that you were using that look back window to define. So the use of the look back window to identify an exclusion criteria that was likely strongly correlated with the outcome of interest made a big difference. When we just used it to define covariates, it really didn't do much. And I suspect it's because, things that are relatively proximal to your index date are presumably going to be the most influential on the actual treatment decision and on your short-term risk of the outcome in general. Things that are more distal, again, the further back you get, presumably the less important it's going to be, unless it's something like a history of cancer that is likely to kind of pop back up again in your follow-up and masquerade as an incident event when actually it's a history of event. So I don't know if this is, no, I'm quite certain it's not good enough to be a hard and fast rule, but I think we can parse a little bit of what is it that we're needing that look back window for, and maybe make decisions that way about which things we would want to use all available time for versus a more consistent, shorter window.
Okay, thank you. Any other questions? I guess it was all very clear.
We're also in the postprandial period, so everybody might be vaguely comatose.
Oh, so we have a question from Chris Hillion. His hand is up.
Hi, Michelle. Thanks for a great talk. I guess I'm thinking, actually, just let me figure out how to put my hand down. I guess I'm thinking about your answer. And I agree very much that it depends what we're using the look back period for. Would it also vary with the data source and what those data are recorded for? And I guess I'm thinking a little bit about, we use the CPRD a lot, which as a general practitioner record, as opposed to a database that contains billing information, whether or not that would vary a bit.
Yeah, I think that's a good point. And I was thinking about it from the, the EHR side in the States, where there's so much fragmentation of the health system that even a quote unquote fixed look back period may or may not mean much. Because you don't really have a great handle on who's in the denominator, going 6 months back, and whether or not events that occurred there would necessarily even be captured by the EHR that you're looking at. And CPRD is a nice example where, in general, populations are stable enough with one GP that you know who's registered at that GP, and they tend to stay there for a long time. So I think you're right that it's definitely data. It needs to be informed by the data source and what pulls people in and out of different data sources.
Well, it's like, because one of the things that is, I think, has been documented in CPRD is that chronic diseases tend to get undercoded after their initial diagnosis, unless there's either been a change to it or that's the exact reason that they're there. Whereas for billing data, particularly if thinking about issues like DRG creep and whatnot, where there's an incentive to be recording at many every comorbidity or complication that you can.
Right. And I mean, that's sort of part of the challenge of dropping into these big integrated data sources for people who don't have as rich of an understanding of the data generation mechanism. Subtleties like, oh, this is billing data, and there's like this much, there's a 5% incentive on your total bill if you have one of these 3 complicating conditions, versus something in the inpatient setting, for instance, where they're going to write down whatever you were actually treated with. So I think that's a great point.
So we have a question from Dr. Suissa.
Hi, Michelle.
Hello.
Thank you very much. A very informative talk. I appreciate very much the topics that you addressed, and particularly the one regarding interactions and subgroup analysis. I think this is extremely important because we are more and more going to replicate randomized trials, and randomized trials inherently will have a figure, always a forest plot systematically, where they give you 20 different
Yes.
subgroup analyses, and here, by replicating them using the observational approach, what you are saying is don't use interactions systematically, because there may be some confounders that vary differently between the different strata. Now, can you practically suggest an approach that can be some kind of a validation tool or a diagnostic tool to evaluate whether we are biasing those stratified analyses?
I mean, the simplest approach, which is arguably labor intensive when there are 20 subgroups that you want to interrogate, is to do the stratified analysis and see if your treatment effect looks similar to what you obtained when you just put an interaction term in between the treatment and the subgroup of interest in this single overall model. If those two differ, I think you have a strong argument that there was residual confounding in the capture of the covariates that you were not reflecting in that overall model that you fit. But I recognize that that is, again, when you have 20 different subgroups that you're trying to replicate from the trial that presented all of those, that's labor intensive. And in addition, you often end up in small strata. And actually the trial has the same problem. The trial probably has residual confounding when there are small groups, since they may not achieve balance and expectation when they're randomizing a relatively small number of individuals. So I guess the problem lands actually on both sides.
So something to be aware of. Then.
Absolutely.
Yeah. Okay. Thank you very much, Michele.
My pleasure.
Thank you. Do we have any additional questions? Okay. So we have 2-3 minutes left. It's a last call for questions. Okay, so in that case, I'd like to thank you, Dr. Michele Jonsson-Funk, for your beautiful presentation. And this will also conclude our seminars series for CNODES. So thank you very much for being the last speaker, but this was fascinating, and you certainly tackle a lot of the issues that are present in pharmacoepi and real-world data in general. So thanks again. I think this is a nice way to conclude our series. I'd like to thank everyone for attending. So thanks to everyone, and have a great summer.
Thanks.
Take care.